I'm now going to hand over to Dr. Kayembe, who is one of our senior medical officers at the Family Medicine Department, and very good at being able to translate what's in the guidelines into daily practical use. Thank you, Dr. Kayembe. I'm handing over to you.
Thank you, Dr. Muller. Good afternoon or good evening to everybody that participating this afternoon. Just
Dr. Kabengele, you've muted. Just double check, you've muted by accident. We can't hear you.
It is on now. Hello?
Yes, we can hear you, Doc.
Okay, so the case that we share, it's just a reminder that every single challenge that we get when we deal with our patient, or any prescription that we made, any outcome from our patient is an opportunity for us to learn. And we should, from time to time, being it in the department or in meetings like this, share our experiences and the knowledge so that we can standardize the management of our patient. So while it may seem small today, it is just the beginning, and hopefully we will get to treat our patient better, and most of all, treat our patient based on the latest evidence. So this is the patient that we'll be talking about. She's a lady about 60 years old. She's a professional nurse. She's a mother of 3. She has a medical aid. She has a medical aid, but she's getting a treatment at the clinic, but at the clinic, meaning in Ward 5 staff clinic, but she also come to the family medicine department. And from time to time, she will still go to her GP or to private sector whenever the need arises. So she has hypertension, she has diabetes, she has asthma, she has lower extremity arterial disease, and she also has dyslipidemia. We all know most of our patients hardly come with one disease. They will always, especially in the context of non-communicable disease, come with multiple chronic conditions. And there are diseases that tend to come as a cluster. This is not something random. It has been published as a, and between 45 and 65, as you can see, almost 25% of patients will have at least 2 chronic conditions at the same time. So this patient comes to us or come to you for the first time because she is worried that she has been having recurrent symptomatic level 2 hypoglycemia. And a month earlier, in the morning while preparing to go to work, she got dizzy while showering. She fell and sustained a traumatic brain injury, and she was admitted because of hypoglycemia. Here is that, are we all comfortable when it's just written we deal with hypoglycemia? Do we take time to grade hypoglycemia, or we just write hypoglycemia? So whenever they say level 2 hypoglycemia, which criteria do you use to decide that the patient has a level 2 hypoglycemia? So it is basically shared levels that are less than 3. That is what is called level 2 hypoglycemia. Just a reminder of the classification of hypoglycemia in the context of diabetes in particular. So at 3.9 already, it is a value that needs to be considered as an alert. And at 3, already you have what is called a clinically significant hypoglycemia. We all know the signs and symptoms that we look, being it neurogenic or glycopenic. And I hope we all remember that when it comes to severe hypoglycemia, it is not about the number, but the fact that there is cognitive impairment and the need for external assistance. There, we've tested our patient, or we educate our patient, or take history from our patient about occurrence of hypoglycemia. We need to use to know our hypoglycemia. So first, it should, for this patient, for example, because there was a value that was there, and the patient reported the symptom, documented hypoglycemia. Severe, we discuss about it. And we also know that some patient might have is totally asymptomatic and they are not even aware of what is happening. And there will also be patients that will report, especially those who don't have glucometers, after experiencing previous hypoglycemia, they might report symptoms that are consistent with hypoglycemia, but unfortunately, by lack of testing, they won't have a documented value. Those patients will be documented, or which should be recorded as reporting a probable symptomatic hypoglycemia, while there are also patients that might report signs and symptoms of hypoglycemia while the value is consistent with the one that I'm talking about. Those patients will be ascribed the classification of pseudo hypoglycemia. And when it happens many times, more than once, it is a recurrent or the recurrent hypoglycemia. So this patient comes to us and report that she took by herself dextrose 50%. These are the notes from the nurse, and blood glucose was rechecked after 30 minutes, and it happened to be recorded at that occasion to be at 3.2. These are not found in a patient file. So just to let you know, as we were talking about small things, these are things that we take for granted. We all think that because it's here hypoglycemia that we see almost every single day, we are enough and consistent and standard in the way that we put our notes or assess our patient or even manage our patient. So first it's written just patient took dextrose 50%. The time that it was taken doesn't appear. The amount of dextrose that was given doesn't appear. And as you can see, they took 30 minutes to recheck the blood glucose after dextrose administration. So when we appraise this, because that is the exercise that we need to go through whenever we review a case, it just to remind one another the rule, it just the rule of 15 by 15. If we were all mindful of this rule, of dextrose 50%, because that is what will provide to the patient 10 grams of glucose, because
Dr.
the recommendation again, yes.
You just when you were about to announce the rule, you blanked out for 20 seconds. So just tell us again what the 15-15 rule is. There was just a little bit of a web interruption.
Oh, okay. So the 15-15, it just means in patients that are conscious but experience hypoglycemia, provide at least, or the minimum will be, or the optimal amount of glucose to provide is 15 grams of glucose. And the other 15 means that you should recheck your patient blood glucose 15 minutes after administration, oral administration of glucose. That is the 15-15 rule. So, and in this case, because the dextrose was provided as a solution of 50%, if you want to get 15 grams of glucose using dextrose 50%, you need to document or order that 30 ml of dextrose 50% is given to the patient. Because when you give 50 of 50%, it means you've given 25 grams of dextrose. So these are other modalities that can also provide 15 grams of dextrose that I need to be told to the patient as we educate them, because we cannot manage a diabetic patient without stressing how critical it is for the patient, not only to recognize, to avoid hypoglycemia, but if it does happen, how to recognize that they have hypoglycemia unless unaware of it. But in that case, being the patient himself or the relative or the friend should be able to know which modality and which amount of that particular modality can provide them with the 15 grams that are needed for every patient that is conscious. So again, recheck. It is recheck the blood glucose 15 after providing that 15 grams of glucose orally, not 30 minutes. But we also know that once we've rechecked, as long as hypoglycemia persists, the treatment should be repeated. As you can remember, the patient 30 minutes later was still having 3.2 as glycemia, but there was not a formal order and documentation of a repeat of dextrose and a repeat of monitoring for us to ascertain that hypoglycemia did resolve. Again, once it's normalized, it is challenging at times, even in Ward 5 or in casualty or A&E. By normalize, we forget that once it is normal, they need to get something that is slowly digestible so that they can prevent recurrence of hypoglycemia. And some of these patients comes to us, they don't have money, or they didn't carry food with them, or they don't have a relative who can go out to look for food. And we should as providers, be mindful of the fact that if this is not followed up, and the journey back home will be long, they might encounter another episode on the way home. So, but when hypoglycemia is severe, we need a treatment that will quickly correct hypoglycemia. And in that instance, what we do, it is that dextrose 50%, but that will be given IV. And again, you can see between 10 and 25, the 15 still appear there. So people must know that it will depend on how severe or the hypoglycemia is, or at the time it will depend on the clinician preference. There will be clinician that will give less than 50 ml of dextrose 50%. There will be a clinician that will give 20 ml of dextrose. As you can see, the one that gives 20 or the one that gives 50, no one is wrong, because at the time clinicians tend to want to fight out of nothing and say 20 ml. The amount of dextrose that should be given can be given between 10 and 15 grams, meaning between 20 and 50 ml of dextrose. And in that case, because it has been given IV, you don't wait for 15 minutes. You can already assess your patient response by 5 to 10 minutes. And the target in severe hypoglycemia is to get the blood glucose to 4.4. And once you have 4.4, then you can start maintenance using a dextrose in water 10% that will run almost at 250 ml per hour for 24 to 48 hours until the patient is awake and normoglycemic. This implies that the patient will need to be admitted, or if you have an institution that have a short stay, that the patient should be there for 24 to 48 hours, particularly if they got hypoglycemia on long-acting insulin or on sulfonyl urea. So, and we at the time we have challenges with internal medicine. Some of the internal medicine providers that will just tell you, but the patient is well, the patient should go home. You should be able to document properly that, and never agree to discharge the patient because sulfonyl urea in particular and long-acting insulin will last almost more than 12 hours at time, close to 24 hours. And failure to keep the patient, give maintenance, monitor, and because even when they are on maintenance, you will still need to monitor the patient blood glucose on a 4-hourly basis. So now you go back, we're going back to the patient. That acute phase is past. Now you need to find out what is the reason why the patient developed hypoglycemia. As you can see, she was diagnosed with diabetes and hypertension in January 2019. And for those two conditions, she's receiving on paper 8 CMH, glimepiride 6 milligram daily. She's also getting hydrochlorothiazide 12.5 daily, enalapril 5 milligram daily, amlodipine 5 milligram daily. And later on, when she was diagnosed in September, which is also another issue, because this lady was diagnosed with diabetes beyond 40 years. At that stage, at the diagnosis, she was supposed to be given already simvastatin or a statin based on the levels. The target is already known here based on the level of baseline LDL. We should have chosen the appropriate statin for her. But check again here, the patient is diagnosed with diabetes in January, but because they didn't pull blood for lipid, the patient spent 8 months without a lipid, without a lipid lowering treatment until the day they got cholesterol tested. And in the meantime, also in November 2019, which is only 10 months after being diagnosed with diabetes for the first time ever, she will also be diagnosed with lower extremity arterial disease, what people used to call peripheral arterial disease, which is another reason for the patient to be on not only to be on statin, but that should have been another reason for the patient statin to be escalated and aspirin to be now given as a secondary prophylaxis. So, because the patient must go home and it has been recurring, we need to work on preventing this from happening. And the patient is really worried. And we all know that maybe the next time she will not be as lucky as she was, that she didn't carry disability post a fall. So what are the risk factors for this hypoglycemia in this patient? So obviously, even in the folder, the culprit that was indexed was glimepiride, the 6 milligram that was prescribed to the patient. And we all know that if the metformin and the other new agent are just plus one risk for hypo, we know that the second generation of sulfonylurea is twice likely to cause, more likely to cause hypoglycemia than metformin. And the old generation of sulfonylurea, which is the glibenclamide, the second generation is glimepiride, and gliclazide. So the glibenclamide, for example, is 3 times more likely to cause hypoglycemia compared to metformin. And at the top, you have all your human insulin. Analog insulin cause as much hypos as the first generation of sulfonylurea. So, and again, not all sulfonylurea are the same. That is the reason why we got away from prescribing our patient glibenclamide, and no patient currently should be started on glibenclamide. As you can see, it is almost more than 6 times or more than 5 times the risk of a patient on glibenclamide to get hypoglycemia when you compare with gliclazide, and almost double when you compare with glimepiride. That's why the government have moved and recommend that we all move all our patients. Currently, we only start patient on glimepiride, but unfortunately, there are still some patients from clinics and even at the hospital, some patients that are still, that were not switched to glimepiride. We jump today, almost every time that we see a reference, we have the itch to switch those patients to dolutegravir. We should be having the same itch to switch every single patient that is on glibenclamide to glimepiride, and never think of even initiating a patient on glibenclamide. So besides the molecule was there, whenever you deal with hypoglycemia, that contribute to recurrence of anemia. And among them, we all know that when the patient exercise, when the patient didn't eat enough as usual or skip a meal, they might develop hypoglycemia if they didn't eat properly or they didn't use the correct dose. The more intense the treatment is, the likely is the risk for the patient to develop hypoglycemia. When your patient gets chronic kidney disease and the eGFR drops, the risk of especially from insulin and sulfonylurea increase. Ingestion of alcohol contributing factor to contributing factor to hypoglycemia, and a patient with impaired cognition is more likely those signs and end up not using the treatment properly, but even when this sign kicks in, they might not recognize them or not manage them appropriately. So in this patient, maybe because the decision will be taken by the clinician to 4, so we might consider the intensity of therapy on top of the nature of the molecule that is prone to causing hypoglycemia to also contribute to what was happening. So the management was that the patient glimepiride will be dropped from 6 to 4. But I wanted that to have a discussion about, yes, it is on paper, it is written that we can give up to 6 and even 8 milligram of glimepiride, and but we also know that the usual dose that we see our patient and our patient should be on should be between 2 and 4. How many times do we go to 6? How many times do we go to 8? And are we all aware that we really don't get anything from further increasing glimepiride above 4 milligram? Because as you can see there, the change in HbA1c from doubling the dose from 4 to 8 is only lowering the HbA1c by 0.1. So if your patient is off target, doubling glimepiride will never take your patient to where it should be. And we know the price that the patient pay with this glycemic legacy. So why waste time increasing the dose for a drug that really doesn't give you any benefit when it comes to controlling hyperglycemia. So the dose was dropped, but again, as you can see there, she continued to have almost about 2 episodes of hypoglycemia on a monthly basis. She was sent to the dietitian, she went to the physician, she did her best, but every time she will be late on a meal, she will get hypoglycemia. And is there something that we are missing? Why is it that currently we drop? She is a professional, she is educated, she does her best to stick to the rule, but she still has hypoglycemia that recur, not only symptomatic, but also severe at time, because from time to time, her daughter or her sister will need to assist her in getting dextrose while they are waiting to take the patient to the hospital. So again, remember when I was presenting the patient, I told you that she had a medical aid, and from time to time she will go to the GP, and when she was diagnosed with diabetes, she did end up being admitted, and she was discharged, and the clinician that discharged her from private did submit to the medical aid a prescription for chronic medication, part of the prescribed minimum benefit. So basically, there was a gem from James that was behind her carry on getting hypos. She was in fact getting her glycoside HMR 60 milligram from the medical aid on top of the 6 milligram that the public sector was giving her. This is shocking, that because when you flip the pages, 6 months before this, there was one clinician in the public sector that wrote that the patient was on glimepiride and glycoside. But the next clinician never spoke about it. The lady was carrying this treatment from time to time to the hospital. So it looks like the doctors couldn't make the connection and recognize that glycoside that was part of the treatment that she was getting from the medical aid was in fact a sulfonylurea, and giving glimepiride on top of that shouldn't have been allowed. So that is one thing. This was just an opportunity for us to know, to start spotting the difference between the way some of the drugs that are used in the private sector in managing diabetes, that those drugs might be different from the one that we use. And we are bound to know them because patient, being it with active medical aid or once the medical aid have been exhausted, will come back to us. We need to know which drug was playing which role and avoid duplication like this that could have been fatal for this lady. So this was the first part when it comes to the patient. If there are no questions, then I will move to the second part.
Feel free to put questions in the chat, guys, or you can put your hands up if you do have any questions. Otherwise, we can move on.
Okay. The other thing that I wanted to highlight was also the fact that she is asthmatic, and she was also getting her treatment from the medical aid and part of the PMB again, and she has been for about 10 years. And
Dr. Kay, we've lost you. Your connection might have been a little bit weak. You were just starting to tell us about your patient. We can't hear you at the moment.
Okay, is it clear? Is it back now?
No, you're back now. You can just start again telling us about her asthma treatment.
Yes, so it is again another opportunity to dive into asthma management, as we'll be discussing with the following session. So this patient from the medical aid. So at the dose of 50 micrograms, she's using one dose as a control. She has been on it for 10 years now. Confident can we, if she comes to us or whenever she might need that prescription or to substitute this treatment, how comfortable will we be? This patient is on this treatment for us, did prescribe such treatment to our patient, and will recognize that if this is the controller, what will be the reliever, especially that now we in CMH, for example, we have access to budesonide formoterol that we use as a controller and as a reliever in the patient that we've chosen to start on formoterol budesonide. So if a patient is on salmeterol, a LABA, a long-acting beta agonist, a fluticasone, it is a ICS. So in this case, the only treatment that she should, even if she come and ask for a reliever, if she run out of reliever, one should not pick formoterol budesonide as a reliever. Although budesonide formoterol can be a reliever for budesonide formoterol as a reliever for somebody that has a LABA that is different from formoterol. Again, I hope we will discuss as coming. People will have to can understand what I mean. And so again, when a patient has treatment like this and you make an assessment, you know that the patient is asthmatic. The same way that we care about somebody that is on ARVs, which is the patient on first line, second line, third line. We should know that in asthma, your patient can be on step 1, step 2, step 3, step 4, step 5 of treatment. Can we recognize and put this patient on the appropriate level? Because whenever you assess your patient, you need to be assessing your patient with that in mind. So basically, on ICS, the first step is your patient by approximating the intensity or the dose of your ICS. So in this case, the patient is getting 250 twice a day of fluticasone. As you can see on this table, when you have 500, but more than 250, you have medium ICS. So the patient, for fluticasone here, the patient is using a medium dose of ICS. So if you wanna put, let's say the patient doesn't have fluticasone or doesn't tolerate, or there is a contraindication to fluticasone, for example, and you need to move the patient to another ICS, and you still need to remain at medium, this will be the equivalent of 200 and 400 beclomethasone. And this will be also when you use budesonide, it will be between 400 and 800 of budesonide. It's just a reminder that whenever we see these patients, whenever we want to copy and paste a repeat prescription, we need to understand what we are doing, because ultimately one day there will be need for you to adjust the patient treatment up or down. How will you go up and down when you don't know at which level your patient is? So by spotting your patient ICS dose, then you can put your patient, you can know exactly where your patient is on this 1 to 5. And the patient is at the bottom. The patient is using a SABA as needed, as a reliever, using a medium dose of ICS LABA. It means when the patient was given that treatment, that prescription, that patient was given a step 4 treatment, because in asthma, not every single patient should be started .
Dr. Kay, we've lost you again. You were just starting to talk about that not every single patient gets started necessarily at track 1. You have to access where they are. You were just starting to talk about that.
Okay, is it back on?
Yes, you're back on.
Wow, okay. So sorry for my internet today. I don't know what is happening. So I was saying that once, so whenever the patient was given the 500, the twice 250 microgram of fluticasone, that means she was getting medium dose of ICS. It means she was at level 4, and that prescription was made based on the severity of asthma on that particular day. So every single time that you want to start your patient on treatment, you should assess your patient severity. So if your patient severity is at 3, you cannot start your patient at step 1. You will start with step 3. If your patient severity is at 4, you will start at 4. And how do we assess the severity of asthma? It is basically, it is the symptoms. You inquire about your patient's symptoms. I lost that slide. I lost the slide. Okay, you inquire about your patient's symptoms. So if the patient, step 3, for example, you will ask your patient about the daily symptoms. If your patient has symptoms most of the day, of the week, it is your patient should be started at 3. If your patient has a symptom every day and your patient is awakened every night, your patient should be given treatment at level 4. But if your patient only have symptoms 4 to 5 times in a week, your patient will start at a lower level. So you need to remember that you need to assess your patient severity first and start your patient at the appropriate level. But if your patient has been told about, you need to also give your patient a comprehensive education on asthma, because it's not only about medication, it's about triggers, it's about adherence, it's about comorbidities and all those things. If you give the correct treatment and the correct technique also of the device, you will assess your patient 4 weeks later for control. So every time now you prescribe the correct treatment, like when you prescribe ARVs, you want to get your patient suppressed. When you prescribe the correct treatment of asthma, you want to get your patient control. And one of the quicker questionnaire that you use is to assess how many times they got symptoms during the day, how many times they got for the past 4 weeks. So you tell your patient when you come, you need to be mindful that I will ask you these questions. So if the patient says no to all these 4 questions, the one that are there, your patient is controlled. If your patient say yes to 1 or 2 of these questions, your patient is only partially controlled. If your patient say yes to 3 or 4 of these questions, your patient is not controlled. Then you need to find the reason why. So you do the ABCD of asthma, not only of ARVs, and you find the reason and you address. In that case, you might need to move if adherence is not the issue, if triggers are not the issue. If the issue, you would need to move your patient to a higher step. But if your patient control for more than 3 months, you should consider dropping the patient to a lower level and reassess, because it is to control asthma with the lowest dose effective of ACS4. Patient has been taking treatment for more than 10 years at a level 4, while she only got her when she got COVID this January. It means she's been using a higher dose while it was no longer needed. She was supposed to be downgraded to 3, maybe even lower to 2. And when you downgrade, this is just level step by step. When you compare the 2 tracks, because a patient can move from one track to another, but when you move, you need just to be mindful of the fact that you will never take formoterol use down as a reliever. So you will just move the patient to the track above, or you move the patient on the track below, but never mix match the treatment. So I think I'm done for today. Key issue that I wanted to highlight as we see our patient. So you can see a patient, let us learn to document. Let us, when you see a treatment that you don't recognize, why don't you? We Shazam music. Why can't you Shazam that treatment to find out what it is all about? Shazam, you can Shazam by picking the phone and calling a colleague or a friend, or you write it down and go read about it, so that we avoid giving double sulfonylurea to a patient and almost cause irreparable damages to the patient, and also avoid exposing patient to higher corticosteroid dose that she might not need for now. Thank you very much.
Excellent. Thank you very much, and beautifully on time as well. We've got a bit of time for questions, and we've covered on lots of little different things. People can either put questions in the chat, or they can, if you would like to actually speak, you're welcome to. You can just either chat, either put your hand up. If you can't find the hand to put up, you can just unmute. When we close this meeting, a little survey will pop up on your screen where you'll have the opportunity to tell us about any other specific topics Dr. Kay might want to cover in the future. We will go with cases and scenarios that we see in OPD, but it's also useful to know what kind of things are stumping you guys out there in the peripheries. I'm just seeing nothing urgent seeming to come up.
Hi, Doctor.
Yes.
It's Carly speaking. Can I ask a quick question? With at the moment with MH, where we're out of stock of the budesonide and the salbutamol, where we're using the Symbicort as a relief and a controller. I've heard of a few different things, but should we use the same strength as a reliever then, or should we, like if someone's on a controller of 164.5, should they be on the highest strength as a reliever or on the same strength? Thanks.
Okay, so all that you need is first find out where your patient was with the beclomethasone or with the salmeterol. So if currently in CMH, for example, let's say if your patient was getting a low dose, that's why I brought up those table of low dose. That's why I brought up that concept of dose of ICS, because you can only move your patient knowing at which step the patient was. So if the patient was getting a low dose ICS of salmeterol as a controller, that patient will be moved to a low dose of budesonide formoterol as a controller and a reliever. So you see the purple, the patient that is using the purple device A will be moved to using the 160/4.5. So you will prescribe 2 devices of 160/4.5 because at 3 you need a maintenance controller. Formoterol 1 and 2. Formoterol is a controller and reliever, but it is used as needed. While from 3, one of the device must be used as maintenance. It will be used twice a day, but it will be low dose. So you move a patient at the bottom, low dose ICS fluticasone to low dose ICS formoterol. It will be budesonide formoterol, but the patient must get 2 devices. But if your patient was, let's say, on beclomethasone, isn't it, low dose of beclomethasone as a controller with salbutamol as a reliever? Because we don't have salbutamol, you don't give beclomethasone. You move the patient to low dose of budesonide, that Symbicort. I don't like to use that trademark. Let's get used, because tomorrow you'll get another trademark, then you'll be confused. So you rather remember formoterol budesonide low dose, but in 1 and 2, patients basically use it when they are only short of breath. When they are not short of breath, they don't use it.
Thank you very much. Great question.
Thanks,
I'm not seeing any other hands or anybody else unmuting. So with that, I would just say a huge thank you for this wonderful presentation. Dr. Kay always does a lot of effort with his slides as well. So they're always beautifully made and very clear and helping us get us through all the nitty-gritty details of looking after our patients. We're going to attempt to do this every, or at least most Thursday evenings. It looks like the 6 o'clock works fairly well. So we'll keep you posted for the links every week. Have a lovely evening, guys, and we'll see you next week, Thursday.
Bye.